Okay, let's talk about pancreas and how to make the diagnosis, staging, and surveillance of patients with pancreatic carcinoma. Basically, MDCT of the pancreatic adenocarcinoma. This is the classification of pancreatic neoplasms. And we have 4 big groups. The one coming from exocrine cells, the other one from endocrine cells, the other ones are non-epithelial tumors, and finally secondary lesions. Basically, from exocrine cells, we have ductal adenocarcinoma, which is the most important, and most of the presentation is based on that one. Then we have the acinar cell carcinoma, the solid and pseudopapillary tumor, IPMN, mucinous cystic neoplasms, microcystic adenoma, pancreaticoblastoma, very rare tumor. We have 1 case here in the last few years, and cystic teratomas. Most of the ones in that group are with cystic component, but again, we'll see basically adeno in this presentation, and then I will have another presentation for the cystic tumors. For endocrine cell tumors, islet cell or neuroendocrine from insulinomas, gastrinomas, lipomas. These are different tumors that can affect the pancreas. Small cell carcinoma also. From non-epithelial tumors, lymphoma, and secondary lesions can be from different sources adjacent to the pancreas or from the chest also. 1, 2, 4, 4, I don't know who's here. Yeah. Thank you. Some of the numbers that we have: 28,000 deaths per year in United States for pancreatic cancer. It's the 4th leading cause of cancer death in both men and women. Bad prognosis. When you see, this is from the American Cancer Society, you can see the 5-year relative survival rate. And look at pancreas in all stages is less than 5%. Obviously, if you have diagnosis with distant metastases, is less than 2%, and with regional disease is 11 and 10%. It's less than 7%. I would say is probably with some type of pulmonary tumors are the ones with less survival at 5 years. If you see, some lung and bronchial tumors can have less than or around 2%. Basically, this is based because the tumor is usually small, and the pancreas doesn't have any capsule, any serosa, and the tumor can spread locally, even when it's small, can affect the peripancreatic nodules, lymph nodes, and also invade adjacent organs, making the patient non-surgical. The clinical features of the pancreatic adeno is the most common type of primary malignancy, 80 to 90%, usually in between the 6 and the 8 decades. Associated factors: smoking, chronic pancreatitis, prior gastric surgery, exposure to radiation or chemicals can affect the pancreas and act as predisposing factors. Symptoms are usually non-specific: weight loss, jaundice, abdominal pain is usually the most frequent late symptom and is due to extension into the celiac or mesenteric plexus. The pain is can be from epigastric pain to back pain, and is non-specific. Thank you. Serological markers, we don't have anyone for screening. We use 19-9 for tumor detection. Unfortunately, The sensitivity of this marker is when the tumor is usually 3 centimeters or around 3 centimeters. And the specificity of this marker is between 60 to 70% because it's also seen in other tumors such as gastric carcinoma or colonic carcinoma or cholangiocarcinoma. There are some papers in which they talk about the role of the tumor markers in the prognosis and response to treatment, especially for prognosis, how high is the tumor marker when the patient is diagnosed with pancreatic carcinoma. And this is the picture that we have. No? Unfortunately, if you go to the last 2 sentences, you will see that probably what we want in a patient with pancreatic carcinoma is early detection, obviously. But usually this is around 15 to 20%. It's pretty low. 50% has metastasis at time of the dictation, 15 at time of the diagnosis, 15% with local invasive disease, which is unresectable. And what happened with these tumors is there is a group of patients in which we cannot be sure at time of the diagnosis if this patient is a surgical candidate due to we cannot predict accurate invasion of the vascular structures or peritoneal metastases or other lesions that can be present. And we said that these patients are the borderline patients, the patients that usually we give the benefit of the doubt, and these are patients that it can be open and see if the patient is resectable. Therapeutic options. Combination therapy is the one that they are using most, and but resection of the tumor is the only potential curative therapy, and this is, as I said before, less than 20% at time of the dictation of the diagnosis. Surgery with positive margins is not giving any survival benefit. That's why the key for local staging is to select, is to make adequate evaluation of the vascular structures. And we'll see some examples later. To make the exam, we have different possibilities. In our institution, we use the dual phase exam. We don't do arterial, pancreatic, venous, and precontrus phase. In this one, we use here we use only the pancreatic phase, which is at 35 seconds. And this phase is very good also for evaluation of arterial structures. Pancreatic phase is the one that you can see the highest enhancement of the pancreatic parenchyma, and usually these tumors are low-density tumors that can be identified with detailing in the pancreatic phase. Venous phase is done for evaluation of venous structures and for evaluation of metastatic disease, like in the liver. In our protocol, we are using now the neutral contrast. Neutral contrast can be or water or volumen. We use volumen here. Volumen is a suspension of barium sulfate, which is 0.1% of barium, and disappears on the CT with the same density than water. The benefit of that is the water is absorbed and the volumen stays in the GI tract, causing distension of the lumen. When we do the examination, obviously, we can go to the workstation and make different multiplanar reconstructions. And these are an excellent tool for diagnosis and for characterization of the tumor, especially if you are evaluating the possibility of invasion of adjacent solid organs or vascular structures. In this case, we can see how the tumor is distending the intrahepatic biliary system. We have stent in this patient. We have also the pancreatic duct dilated, and we have the proximal pancreatic tumor. The tumor is well differentiated from the normal pancreas in the coronal view, like in this case. But I suggest you to use is a curve reconstruction for pancreas. Why? The anatomic disposition of the pancreas, usually the tail is higher than the body and higher than the head and the uncinate process. That's why usually you don't have the whole pancreas in a couple of images. You have to go up and down. But if you do a curve reconstruction like this, you can probably see the whole pancreas from the tail to the head in just one image. In this one, this is the same patient that we saw before. We have the significant dilatation of the pancreatic duct with parenchymal atrophy, which are both are signs or as suspicious for malignancy, and also we have the pancreatic tumor at the head. Most of these tumors are located in the head, 60%, 15% for the body, and 5% for the tail of the pancreas, and most of the time are focal lesions. Low-density lesions with significant desmoplastic reaction. That's why this fibrotic tumor is very difficult to get biopsy of these before any surgery to determine what is the histology. And the tumors are infiltrative tumors without any capsule. 20% of the cases, the involvement is more diffuse, and you can see multiple segments of the pancreas affected, but most of the time it's a focal and usually small lesion. What are the imaging features? If you do a CT without IV contrast, probably you will miss. What you can see in this kind of tumors, you can see indirect signs. For example, ductal dilatation, double duct sign, parenchymal atrophy, adenopathy. But sometimes, if the tumor is small, you don't see it without IV contrast. With contrast, as I told you, is hypodense, the lesion. And in 10% of the cases, the lesion is isodense. And is best recognized by the indirect signs that I mentioned before. Keep in mind that the double duct sign, described by Patrick Frenny years ago, is the dilatation of the biliary and the pancreatic duct, and should be considered a sign of obstruction. Only malignant? No, not only malignant. Can be seen also in chronic pancreatitis. That's why when you see double duct sign, doesn't mean that the patient has malignancy, but is very suspicious for that. Another example, look at here how you can have the atrophy and the ductal dilatation, and also we have evidence of intrahepatic biliary ductal dilatation. We are going down. We have the SMA, SMB, SMA. We have the pancreatic head and the uncinate process of the pancreas, and you can see how this ill-defined low-density solid lesion is affecting the pancreatic head and causing the dilatation that we see distally. Be careful with the interrupted duct sign. These are findings that you can see in the pancreas, and sometimes you have just a segment of the duct that is prominent, and then you don't see much, and then you see prominent again. This can be indirect sign of pancreatic malignancy. In this case, let's see this movie. We have the ductal dilatation. What else do you see? focal rounded low density abnormality. When we go to the multiplanar reconstructions, this is probably the same image. And the question at this point is what's going on with the vascular structures around the lesion. In this case, you can see how the porta is affected by the tumor that compresses and displaces the anterior wall. Vascular invasion in this case is suspected. What is the staging system that we use for this? Is TNM. We use T1 for tumors less than 2 centimeters and just confined to the pancreas. T2 is a tumor more than 2 centimeters but still confined to the pancreas. T3, the tumor extends beyond pancreas but does not involve celiac axis or SMA. And this T3 and T4 is tumor involves either celiac axis or SMA. Different examples, T1, T2, all within the pancreas, T3 beyond the pancreas, and T4 involving the vascular structures. Remember that the size is not the criterion of unresectability, and we'll see the criteria of unresectability later on. Nodal involvement, N0, there is no regional lymph nodes affected, and N1, regional lymph nodes are affected. And for metastases, distant metastasis turns into N1. Remember that we have to consider the regional nodes are not the ones that are peripancreatic, okay? Are the ones that are distant from the pancreas in the retroperitoneum. And with all this information, we do the staging system from 1 to 4. 1 and 2 are resectable tumors, 3 and 4 are unresectable tumors due to regional lymph nodes involved, encasement of celiac axis or SMA, or presence of metastases. You can go to the books and see this classification. Okay, I think that it's important to remember always what are the criteria of unresectability. Vascular encasement, that can be arterial or venous. I recommend you to use multiplanar reconstructions and MIP reconstructions to evaluate the vascular structures. We'll see this in detail. Nodal involvement, as I mentioned, the lymph nodes are beyond the resection site. Remember that usually for Whipple procedures, there is a block resection, including also part of the pancreas, the duodenum, the fat, the peripancreatic lymph nodes. But the ones that you have to consider are the ones that are in the portal venous system, celiac, or para-aortic nodes. Distant metastases, common places are the liver and can be the omentum. These are the peritoneal carcinomatosis. Sometimes it's difficult to identify when it's in an early stage, and we can miss that and make, or tell that the patient is resectable when it's not. We'll see some examples. And the invasion of the solid organs, remember the duodenum doesn't matter because the duodenum can be resected, but direct invasion to the stomach or the colon makes the patient unresectable. There is a classification considering the arterial involvement, and depending on that, see if the patient is resectable or not. For the venous involvement, there is variability depending on the surgeons and the institutions. But what they said, basically, you can remember is this: a long segment of involvement that is considered more than 2 centimeters, or thrombosis of either the SMA of the portal vein is usually a contraindication. Again, this is depending on the surgeon. Some surgeons, they say, no, venous invasion to me is unresectable. Other ones, they do it. But keep in mind the long segment more than 2 centimeters or endoluminal thrombosis. I told you that for arterial assessment, we have a classification for CT. It's kind of, I don't know, you can follow these ones, this classification, and you can mention in your impression. But sometimes it's difficult to differentiate if it's A or B and C, you know. Let's see what the book says about this. Type A is a tumor that is separated from the vascular structure because we have fat. Type B is the same situation, but instead to have fat, you have pancreas in between. In these two cases, the tumor is resectable, obviously. There is no vascular invasion. Type C, convex point of contact with the adjacent vessel. This group is the one that I told you before that are the borderline patients, the patients that you can tell, not sure if the vascular structure is affected, but you can go and see. We give the benefit of the doubt. D, there is a concave contact. And in this case, you cannot remove the tumor without partial resection of the vascular structure. E is when the tumor affects all around the vascular structure. And obviously, these are patients that, you know, the tumor cannot be resected with negative margins. The last stage is the one that the tumor occludes the vascular structure, like in this diagram, and you can see, obviously, this is non-surgical candidate. Let's see some examples. Adenocarcinoma affecting the celiac trunk. We have a big tumor affecting the pancreatic body, basically, and you can see how the celiac trunk is affected in its origin. You see how narrow it is. If you compare, this is part of the hepatic artery, look at the density of the hepatic artery, look at the proximal celiac axis, we have heterogeneity, and this is due to involvement of the lumen. Same situation for the splenic artery. Also, in this case, we have a focal lesion in the hepatic segment 6 compatible with metastatic disease. The biopsy was done under ultrasound for confirmation. This was a non-surgical candidate, obviously. Another situation, in this case, encasement of the SMA. And what do you say, what would you think you have to say about the compromise of the vascular structure? C. C is convex contact, no? What about this? You don't think it's more concave? That's why, you know, sometimes it's difficult and there is inter-observer variability. Probably if I have to say, I would say that it's more concave than convex, but, you know, it's depending on the radiologist. Also, this tumor was confirmed and was adeno. Another case in which this is probably a little bit more, you know, convex, and the contact of the tumor with the hepatic artery is very subtle. But still, there is some compression and narrowing of the lumen from the tumor. This is a nice example that I just bring this to show you how fast a tumor can grow and how important it is to have early diagnosis. Look at this patient. The tumor was probably not well visualized here, but you can see perfectly well the SMA and the SMB. This is October 2004. 6 months after that, you can see how the SMV disappeared and now is occupied by a large tumor invading the lumen. And also a new metastasis in the liver. Okay, for nodal disease, this is like in any other tumor. What we evaluate on CT is the morphology. And the morphology should be measured in short axis. If it's less than 1 centimeter, we consider probably a normal node. Doesn't mean that the node has micrometastases. Probably it's a normal sized node with micrometastases. We are missing that. But that's what we use. That is the criteria that we are using. There are some publications that they say that they can do intraoperative ultrasound for evaluation of nodal disease or for evaluation of any other implant. And some people are getting advantage of this modality. This is a pancreatic tumor at the level of the head, contacting the SMV and also showing multiple lymph nodes. These are lymph nodes that can be resected from when they are resected in block. Look at this. This is a case in which you have a metastasis stage 4, right hepatic lobe, but also you have a focal solid ovoid lesion adjacent to the hepatic margin. And probably in this case it's easier to identify this because we have pleural effusion. But without pleural effusion, this is very difficult to identify. This finally was an implant in the peritoneal surface. For metastasis, up to 60% of patients can show metastasis when the diagnosis is made. And there are several papers talking about what is better, if MDCT or MRI. If you go to the numbers, MR appears to be a little bit better, but the clinical impact of that is not significant. And PET can be used for identification of patients when you are in a case that you are not sure if what you are seeing on the pancreas is a true lesion. Other examples, extensive pancreatic tumor, in this case affecting the retroperitoneal lymph nodes. This is a non-surgical candidate, but also if you go up, this patient has multiple nodular lesions in the pericardial surface consistent with metastatic disease. Look at the pericardial surface. When you have a pericardial surface with fluid, but also with nodular pattern like this, think in secondary lesions. This is the PET scan showing the abnormal activity in the pericardial surface and also the retroperitoneal adenopathy and focal pancreatic lesion. The MDCT, the accuracy for detection is very good, a positive predictive value of 90%. Determination of non-resectability, approximately 99%. And depiction for resectable tumor, it's a little bit lower, negative predictive value of 79%, and 79% for dual phase. That's the one that we use here. There is a paper that is very interesting that they compare the surgical path with the MDCT findings. This is from Stanford University, and they consider 48 patients with pancreatic tumor, and from these 20 were patients that they resected, and they follow MDCT criteria. And they see that 85% were really resectable. The pre-op diagnosis was okay. And only 3 patients, the staging was wrong. And 2 of these because they couldn't see liver metastases that were less than 2 centimeters, 1 centimeter, and 1 peritoneal implant. But basically, what this paper says is, the CT probably is not the best imaging modality for evaluation of peritoneal implants or small metastases, but it should be, when the technique is well done, should be very good for assessment of vascular involvement. Let's see some pitfalls and differential diagnosis. Can be developmental abnormalities like annular pancreas, pancreas division, inflammatory processes, sometimes may simulate tumors, and extrapancreatic processes like vascular anomalies or lesions that are adjacent to the pancreas simulating a pancreatic tumor. Look at this, is a very interesting case, not for the patient, but I showed this case before. I don't know if you you saw this one too, but you know, this is a patient that came to the hospital to visit a friend, a relative, I don't remember. When he was at the parking lot, the patient suffered chest pain, and the patient went to ED. They requested a CTA, and the CTA to rule out aortic dissection showed this. Patient asymptomatic at that time, until patient went to the parking lot. We saw this, we informed this mass, and they requested for a biopsy. Remember that this was just a CTA. It's not the pancreas protocol exam. They did the biopsy, and the biopsy, look at the density of this tumor. What do you think about the density? High density, which means unlikely to be pancreatic adeno, because we said that this is a tumor with significant fibrotic component, it's usually hypodense, and if we want to evaluate any kind of hypervascular tumor in the pancreas, we have the neuroendocrine tumors, but are not like this. Usually are smaller, well-defined, pretty bright. This is pre-contrast. This is previous to the biopsy. They did the biopsy 1 time, 2 times, 3 times, came blood, and the surgeon decided to operate the patient. He operated the patient, they did the distal pancreatectomy, splenectomy, they resected the adrenal. They saw that the splenic flexure of the colon was probably invaded. They resected the splenic flexure of the colon, and the pathology came positive. I'm sorry, negative. Came just hemorrhagic pancreatitis. But the bad part of the story is the patient died due to postoperative complications. What I say is, did we have any clue or any tip to say this is probably not a malignancy? Well, the density. If we see the density, unlikely to have a tumor with that density in pre-contrast phase. This amount of hemorrhage is probably from what it was, this hemorrhagic pancreatitis. And keep in mind these findings for the future. Pancreas division is a failure of fusion between the ventral and dorsal pancreas, and sometimes can simulate a mass. This is an example of a pancreas division. You can see follow this and follow this. Going separate into the duodenum. Did you see that? Let's go again. We have the Wirsum coming here. This is the biliary, and then this one is the Santorini. Did you see? 3 different ones. I think this image, 1, 2, 3, separated. This is increasing the risk, you know, it's an anatomic variation, but increases the risk of pancreatitis. Annular pancreas is the second most common anatomic variation, and basically what you have is the pancreas going around the duodenum. associated with other congenital anomalies like Down syndrome, duodenal atresia, malrotation, esophageal atresia, can cause symptoms because the duodenum can be compressed by the pancreas. We have some examples. The best way to identify this is obviously when you see the images, you have the pancreatic head, and then when you look for the duodenum, the second duodenal portion, the descending duodenum, is not present, and when you pay attention is inside the pancreas, like in this case here. Here. If you don't have contrast, PO contrast is sometimes very difficult because it's just compressed and the density can be similar than the pancreas. This is the MRI. This is the pylorus with the proximal duodenum. This is duodenum, now is compressed by pancreas. You see, pancreas here, going around. Pancreas, duodenum, pancreas. If you have contrast, it's sometimes easier, like in this case, that you can differentiate between the pancreas going around and the duodenal lumen. Duodenal lumen, duodenal lumen. And this was the surgical pathology, not the surgical pathology, this is the intraop picture. This is stomach and proximal duodenum that were distended. And here is the pancreas going through the second duodenal portion, or around the second duodenal portion. This was another case. Patient came with abdominal pain, and we have this CT. We have this ill-defined low-density abnormality at the level of the pancreatic body. Remember that the splenic vasculature goes close to the pancreas, and the differential at that time was a kind of possible tumor, inflammatory process, follow-up next month, completely normal, was just an inflammatory process affecting the pancreas. This was another case with diagnosis of pancreatic carcinoma by PET-CT. We see the CT scan, and we noted that the pancreas, it was okay, well delineated, SMB, pancreatic duct, biliary duct, duodenum, SMA. This is the IVC with the right renal and left renal veins, and we have in between this structure that was a big lymphadenopathy. Was the one that was positive on PET. Let's see some examples of other solid tumors, like the islet cell or solid and pseudopapillary tumors. Look at an islet cell tumor. When you have the pre-contrast phase, sometimes you cannot identify it, but after contrast, and that's why we need an arterial phase or a pancreatic phase, 35 seconds, is to identify this hypervascular mass. Probably if you go to venous phase, this lesion washes out and it's difficult to identify. SPT, remember, can be in any place of the pancreas. It's a benign tumor with potential malignancy. It has malignant potential, and this tumor can be cystic, can be solid, can be mixed. Depending on the component, you can see, like in this case, on MRI, which is very good for identification of necrotic or cystic changes, you can see how the lesion is mixed with a solid center and peripheral areas of cystic degeneration. But also it's difficult, it's different pattern. No? It's more rounded, it's more defined, it's completely different than the adeno. What is the role of the MRI for diagnosis? In the past, we used to say if the patient is allergic to iodine, we can use that, and we still do that. For patients with abnormal renal function after the NSF, we are not using MRI in patients with renal failure or low renal failure, low renal function. Can be used in different situations, like when you have an isodense lesion that cannot be identified and you have indirect signs, you can do MRI. In this case, I think it's probably to clarify a situation that is not very obvious on CT. I would say problem solving, contraindication to contrast. And still, the MDCT is the most effective imaging modality for diagnosis. Role of PET is giving us metabolic activity rather than morphologic activity. At present, it's not routinely used in the diagnosis of pancreatic cancer because of lack of anatomic detail. And this can be used in diagnosing small tumors that can be missed on PET, on CT, and for identification of extrapancreatic disease. Endoscopic ultrasound is more sensitive than CT and MRI for the identification of small tumors. We are talking about 1 centimeter or less. And also it's good for vascular assessment. But usually you have to have a morphologic evaluation with CT or MRI first, and get ultrasound if it's non-conclusive. In summary, MDCT is still the current modality of choice for diagnosing and staging of pancreatic carcinoma. It is crucial to identify those patients in whom surgical resection is potentially curative and spare the ones with advanced disease, avoiding unnecessary potential post-surgical morbid mortality. MRP, MIP, both are very valuable tools for local staging. And even with MDCT, the problem of undetected micrometastases to the liver and peritoneum remains. And remember, integral evaluation with multimodality assessment can be good for a better diagnosis and characterization. I think this is the last one. Any question? No questions? Very good.